My talk was about personalized medicine for inherited breast cancer. So the idea being that we know that there are high-risk genes where you inherit a mutation. It confers a very high risk of breast cancer, such as a 60% lifetime risk of breast cancer. But not every woman who has that mutation or has mutations in that gene has the same levels of risk. It can vary. Some women could be as high as 80 or 90%. Some women might be as low as the population, which would be 12 to 20%. And so the work that we do is really trying to personalize that and figure it out. So we came here today to participate in the Personalised conference and to share that information with people. If you have a mutation in a particular gene, such as BRCA1 or BRCA2, we look at common genetic risk factors. So there's other types of genetic events that are very common in the population. 30 to 40% of people walking around in the street might have these events. They don't on their own really confer much risk. But when you put a lot of them together, and we've recently published some papers with up to 180 of these different variants, when you combine them all together, you actually do get a very powerful risk factor. And so then when we layer that on top of the high-risk mutations, such as the BRCA1 or the BRCA2 gene, it can modulate that. So if, for instance, if you had 180 of those variants, you'd be quite at high risk, and it would punch your overall lifetime risk up high towards 80%. But if you had only one of those 180 variants, that would be a low risk effect, and it would pull your risk of BRCA1 probably back down to about 20%. So it's all about calibration, moving it around. And in addition to that, then we look at environmental factors. So, exposure to various things, your diet, exercise, so BMI levels, body mass index, obesity, exercise levels, how many children you've had. These are all well-known risk factors for breast cancer. So the whole idea is to put the rare mutations that are high risk, the common mutations that are low risk but can calibrate, and then these common risk factors, and even further calibrate the models. So in the end, the hope is, we're not there yet, but the hope is that we could bring a woman in, do a questionnaire, do a genetic test, and then give back a very specific risk. And the other idea is that it's not just a lifetime risk. So if you look at a woman and say your lifetime risk of breast cancer is 80% or 20%, what does that really mean to her today, sitting in front of you? What she wants to know is, what's my risk in the next 5 years or the next 10 years? Because if she's 30, she's still talking about having kids. She doesn't want to have prophylactic surgeries that remove the ovaries before she has the kids. So you can see that on an individual basis, this can have major impact. If you're a 60-year-old woman learning this for the first time, then you're not so worried about those things, and maybe you deal with it in a different way. The main obstacles for us is just access to the patient information. We need huge numbers to do this. It's all statistically based. And so to have enough statistical power to prove the point, you really need to test hundreds of thousands of individuals. And so we've been doing that in some large studies, worldwide consortium type studies. And that's where these 180 variants have come from that we've recently identified. So just trying to learn that. We're also going back into trying to advance that field a little bit further, looking back into patients who've had specific types of therapy, and looking at all these factors and seeing if you can calibrate their risk and their response to therapy at the same time. So really, again, personalization of risk, personalization of response to therapies, personalization of outcome. It's all feasible today. We have enough information to be able to do this, but we just have to test all these individuals and gather all the data and analyze it. Yeah, I think coming soon for most people, we'll have these personalized risk estimates. It won't be the complete package like I was just talking about, but it'll be an interim package where we will be able to move women up and down. So for instance, a BRCA1 mutation carrier will come in, we'll do this extra test, this extra genetic test, and we'll be able to give her a better estimate of her risk, and she might change her decisions about prophylactic surgeries, etc., based on that. And then for women in the general population who show up in a breast clinic, we're, for instance, doing pilot studies right now where we take people who don't have BRCA1 or 2 mutations. These are just random women with breast cancer. And we're finding that with these common genetic factors that we have, we can put them into high-risk categories and low-risk categories. So the high-risk woman who comes in, maybe she had a biopsy, it was negative, but she's still at high risk and she's worried about her cancer. If we put her in a high-risk category with this test, then she comes back and she does more frequent mammogram screens. But if she's in a low-risk category, then maybe it settles her mind a little bit. Maybe she doesn't have to come back every 6 months for a follow-up. Maybe she comes back every 2 years. And of course, there's a health economics benefit from that perspective. So I think it's been useful across the entire spectrum of breast cancer. All patients can benefit in some way or other from these new discoveries.
you.